So I'll be speaking about anti-hyaloid and reproliferative vascular membranes. So the definition of AHF proliferation is not very distinct or not very clear. So I have described them in 3 or 4 different ways. So AHF proliferation can be post-trauma. Post-trauma is the glial proliferation which happens at the site of the globe perforation and grows inside into the eye. It can be starting from the sclera into the retina, into the choroid. And post-RD surgery, you have this thick anti-hyaloid proliferation which forms in the vitreous base. And this is particularly common in myopes. I don't know why it happens, probably because of peripheral anterior segment ischemia, which makes these eyes proliferate so badly that we may lose some of these eyes to phthisis. And a little distinction is anti-hyaloid fibrovascular proliferation, which forms after diabetic vitrectomies. So here the vascular component is pretty high, and they tend to bleed, and these eyes can be lost very easily as well. So all these will have some amount of vascularity, but the diabetic patients seem to have much more vascularity. Not only diabetics, even a central little vein occlusion or a BRVO, you will find this vascularization of the vitreous space to be pretty high. So how do we identify these patients? So there are some clinical clues when the patient comes for a follow-up. Many of them will have this episcleral or conjunctival congestion, particularly at the site of the sclerotomy. So you will see the proliferation starts at the sclerotomy, goes inside and goes circumferentially. And these are patients who will have recurrent vitreous hemorrhage, not in the early vitreous, not in the early postoperative period. About a month or 6 weeks later, when they come with the vitreous hemorrhage, then we tend to think that they may have a sclerotomy site proliferation, and which may go on to form an anti-hyaloid fibrous proliferation. And later cases, they develop rubeosus iridis, a posterior synechiae, and ultimately they go on to develop iris retraction and hypotony. So what are the issues? If you leave these eyes alone, they go into phthisis. And in gas-filled eyes, what happens is like they tend to progress faster because the detachment and the hypotony tend to progress faster, so better to intervene early. And if in the primary surgery we have filled this eyes with oil, then like it kind of masks the progression of this disease. So we don't tend to see that like they have developed this anti-hyaloid proliferation much later. And like when we take them up for surgery much later, it can be kind of irreversible changes. And when would I not operate? If the patient has a visible retrolental membrane, asking the patient look this way and that way, and through the slit lamp we find this thick tissue which is growing behind the iris, and with long-standing hypotony, I would probably not operate because these eyes either way will land up with hypotony. Let's look at some of the clinical scenarios as to how to manage them. This is this young child with recurrent RD because of juvenile X-linked retinoschisis. So what we see here is the fibrous tissue growing onto the pars plana, very, very close to the ciliary body, ciliary process. The patient is phakic. So in a phakic patient with a thin lens, we can go ahead and remove this fibrous tissue pretty easily without touching the lens. The key is that the lens is not thick, and the amount of depression and correct amount of suction, we can go ahead and remove this scar tissue without touching the lens. So this is a post-trauma localized proliferation, and this proliferation is at the site of the globe rupture. So here we are able to remove this fibrous tissue completely, and this is not a very severe case. You can see this scar tissue is not attached to the iris, not extending posteriorly as well. So you can isolate the whole scar tissue with the scissors and then remove them. And so this, what we see here is the edge of the retinectomy, which is pulling up the retina. So you can remove the scar tissue completely. Then go ahead and reattach the retina. The clue is like you can see the iris is still round, the pupil is still round, it is not dragged down that side. And if it is dragged down that side, that means like the ciliary body in that region would also be scarred down. So the much more serious epiretinal proliferation, one-eyed patient post bomb blast injury. There was an occlusion of pupillae, and the scar tissue is growing from here posteriorly, and you can see this thick scar tissue. So extending nearly about like 3 to 6 quadrants. You can see the inferior retina is pulled up as a kind of a TRD. So the epiretinal membrane is being removed, and you can see the fovea is dragged towards the 6 o'clock. And this is the fibrous tissue which is grown, causing the TRD. So we do a retinectomy there, isolate the retina from the scar tissue, and then go around and see if we can remove the scar tissue, how much we can safely remove. So in the process, I find that there is a foreign body within the scar tissue also, so which we remove, and may not be able to remove it completely, but isolate it at least so that it doesn't grow circumferentially. I usually cut off the ciliary body on either sides of the scar tissue, stopping it from growing circumferentially. So we will be able to attach the retina, but this scar tissue, if we are not able to isolate it or not remove it, it tends to circumferentially proliferate, giving rise to persistent hypertony. So here we see the very often, like not very often, we'll be able to remove this scar tissue completely. So this is the fibrous tissue is grown over the ciliary process. We're able to dissect it off the ciliary process and remove it. And then like we find that it will be attached to the iris as well and dragging it down. So we have to remove the iris from the scar tissue and also see if the scar tissue can be removed off the ciliary process completely. Very often the ciliary body is already damaged, so even if we remove it, the IOP may not improve, but we should at least try. You can see that it's stuck to the iris. We are removing the scar tissue from the iris. Another clue will be if we have put an oil, the PI will get closed. If we find that the PI is getting closed, then again we expect that the scar tissue is growing right behind the iris. So extreme depression, isolating the scar tissue. You can see the PI is closed in this patient, and that's because the scar tissue is grown right behind the iris, and that is what is being peeled right now. Isolate, remove it from its adhesion to the retina and remove it. So not very advanced because the pupil is still round in this patient. So here again, this is not too advanced, but the scar tissue you can see very severe anterior proliferation, so thick that even a 20 gauge cutter will not cut. So with a bimanual dissection, we have removed this tissue from its attachment to the ciliary process, and there's no way I'm going to remove it. So make a section in the limbal section and remove this through the limbus itself. So you can still attempt, because as you can see the iris is still not retracted. Once the iris retracts and goes back, the tissue is so densely adherent we may not be able to remove it. But here, because the iris is still round, the scar, it is not progressed to involve the iris as the ciliary body, can still remove it. A couple of words about the diabetic reproliferation. Diabetic, I think Dr. Saravanan is going to speak to us, but then the reproliferation is not the same as regular proliferation of PVR or regular diabetic vitrectomy. Here again, it's very densely attached and it's vascularized again. So if you find a reproliferation in a diabetic patient, we may often have to do a bimanual surgery, and it may be sometimes more difficult than a primary diabetic vitrectomy. So it's not like an ERM where we just go and peel it off. So in a diabetic patient with a TRD or a combined retinal detachment, if there's a reproliferation, we should be planned to do a bimanual surgery and also expect that these will be vascularized. With one other diabetic patient, you can see there's extensive reproliferation, which part of it we are able to remove with like how we would peel an epiretinal membrane, but very extensive proliferation. And so as I mentioned, sometimes we may have to do a bimanual dissection in these patients. But what happens to the periphery, let's see. So this is what I was mentioning. As we go to the periphery, this is the posterior pole, we are able to attach it, but then peel all the membranes. But here, you see this thick, broad band of tissues, the whole vitreous base is become one thick tissue of fibrovascular proliferation. This is something which we may not be able to remove at all. And in the process of trying to remove it, will cause more harm than benefit, because the choroid may get detached, the ciliary body may get detached, or the ciliary body irreversible trauma we may be inducing into. Difficulties in dissection, yes, we would have to do extreme depression like this and remove them, and very often they are vascularized and they may bleed from this fibrous tissue or from the ciliary process itself, and we may land up like this. The view becomes very hazy because of bleeding, and the blood may seep behind the detached retina because we have done a relaxing retinectomy, and the blood may seep behind the retina. So we would have to wait, and these bleeders cannot be cauterized. So what best would be to do is to stop the surgery, elevate the bottle height, and wait for it to stop bleeding, and then go back inside, remove the blood, and track the clot and leave it in place instead of removing them. In very select situations, and if it is extremely adherent and I am unable to remove it and there's a peripheral traction retinal detachment, I will shorten the sclera instead of removing the fibrous tissue from inside. So create a scleral bed and shorten it. This is a very old surgery described by Skippens for anterior hyaloid proliferation. This is something which very rarely I do if there is a peripheral TRD in a one-eyed patient and I am unable to remove this at all. These are some of the issues. Iris retraction and silicon oil keratopathy can be there, and you can see the iris is retracted here. I expect this will proliferate and the oil can come into the anterior chamber, so you can do a pupilloplasty to make sure that the oil doesn't come into the anterior chamber in these patients. The single pass technique, we should be able to close this and create an inferior iridotomy as well. So these are to be anticipated and done much before we take these patients for surgery, so that they don't land up with silicon oil keratopathy. And when we have patients like this where the whole iris is retracted or lost, you can do the silicon oil retaining sutures. These do retain the oil behind in many of these patients. The other option would be to put an anaerodia implant, which we don't get that commonly. So you can place these sutures in place so that the oil is retained and the cornea does survive to a reasonable extent. To summarize, AHF proliferation is serious and often irreversible. Post-trauma, probably salvageable, these eyes are. Post-RD, possibly salvageable, depending on the extent of the fibrous tissue proliferation. Post-PDR, most often lost, though we may be able to attach the retina and they may be able to get the vision, but then the cornea does go in for a 6 over time. Anatomical success is very often possible. Irreversible ciliary damage, however, results in irreversible hypertony, iris retraction resulting in keratopathy. Thank you very much.